100 clinical presentations. Today's topic is HELP syndrome. HELP syndrome is one of the entity which causes maternal mortality, morbidity, and it needs great attention. This is basically three things are there. First is H for hemolysis, low platelet for LLP, and EL is for the elevated liver enzymes. The syndrome of hemolysis with microangiopathic blood smear, elevated liver enzymes, low platelet in pregnant and post-pregnant females. Patient is more commonly known by the acronym HELP syndrome. This is the case 1. 27-year-old female, gravida 2, para 1, at 35 weeks of gestation, history of gestational hypertension, no significant past medical history, chief complaint, abdominal pain, nausea for the past 2 days. History of present illness, the patient presents in the emergency department with a complaint of abdominal pain and nausea for 2 days. She reports that the pain is severe, especially located into the upper right quadrant of her abdomen. And she also reports that there is a decreased fetal movement over the last 24 hours, and she denies any vaginal bleeding, any vaginal discharge, and no contraction. And she had no fever, chills, or vomiting is there. Then, as being the physical examination being done into the this department of emergency department, her vital signs: BP was 160/100, pulse 100 beats per minute, respiratory rate 18, temperature normal in 98. Abdominal examination being done, and it was found there is a severe tenderness into the right upper quadrant of the abdomen, no rebound tenderness or guarding. Fetal heart rate normal 120 beats per minute not there, and other findings were edema in hands and feet, petechiae on the skin, and on the laboratory findings, the hemoglobin was 8, platelet count 50, then AST is 250 micro per liter, then ALT is 180, and total bilirubin is 3.5, which is a normal, more than the normal range is 0.3 to 1.5. Urine protein is 3+. The diagnosis was made with a clinical presentation and a laboratory finding is a consistent with HELP syndrome. Admitted into the hospital for further management and monitoring. Fetal monitoring is initiated. Obstetric consultation obtained. Management, the patient is managed with a close monitoring of blood pressure, platelet count, liver enzymes, and fetal well-being, as well as magnesium sulfate being given for the seizure prophylaxis and intravenous corticosteroids for the fetal lung maturation being given. Platelet transfusion may be necessary to prevent the bleeding complications. Delivery is recommended in the patients with severe HELP syndrome or the worsening clinical status, and a postpartum monitoring is necessary to ensure the resolution of the syndrome, to monitor for the potential complications such as hemorrhage, thrombosis, and liver failure. Now, how we have to define HELP syndrome, how it works, how it goes on. So these are the points. The HELP syndrome is a serious pregnancy complication, can occur into the later stage of pregnancy or in the postpartum period. HELP stands for hemolysis, elevated liver enzymes, and low platelet count. In a variant of preeclampsia, it is a variant of preeclampsia, and it can cause a range of symptoms including abdominal pain, nausea or vomiting, headaches, fatigue, visual disturbances, and if left treated can lead to serious complications such as liver failure, stroke, and even the maternal and the fetal death. Now, there is a pathophysiology of HELP syndrome. How it happens and why it happens is very important. But the exact cause of HELP syndrome is not fully understood. Number one, it is believed to be related to the problems with, number one, the blood vessels in the placenta and the blood vessels in the liver. The placenta plays a critical role in the exchange of nutrients, oxygen, and waste products between the mother and the fetus. So placenta has got the role and the blood vessels in the liver has got the role. There is in HELP syndrome, first, the damage of small blood vessels in the liver. It can cause the breakdown of the red blood cells. It leads to hemolysis, that is H in the HELP syndrome. It results into the decrease into the number of platelets. It can impair the body's ability to form the clots and lead to bleeding. And liver may be inflamed or swollen, which can lead to elevated liver enzymes, that is EL of the HELLP syndrome, and impair the liver to ability to function, leading to build up the toxins into the blood and potentially causing serious complications such as liver failure. Now, this pathophysiology of HELLP syndrome, underlying cause of the damage of blood vessels in the liver and the placenta, not fully understood, but it is thought it is related to the problem of immune system, and second is inflammation. Now, the factors which that increase the risk of developing HELLP include, first is history of preeclampsia, HELLP syndrome in a previous pregnancy, if there is a multiple pregnancy, pregnancy over the age of 25, having a family history of preeclampsia or a HELLP syndrome is there. It may represent a complication or progression of severe eclampsia. However, the relationship has been challenged by the recent evidence that they may be separate disorders, as a preceding hypertension or a proteinuria is absent in at least 15 to 20% of the patients with the HELLP syndrome. So we cannot say if the patient is having preeclampsia can have the HELLP syndrome. HELLP syndrome can be an individual entity because sometimes there is no proteinuria in those cases. It is unclear, but it is thought to it's a systemic inflammatory disorder and mediated by the complement cascades. There may be overlap with a similar pathogenesis as in preeclampsia with a poor placentation. Unknown reasons, it can be exacerbated by the activation of the complement system and greater hepatic inflammation in a patients with the HELLP syndrome. A subset of HELLP syndrome is known as hemolytic uremic syndrome, that is HUS. It is a complement dysregulation associated with the thrombotic microangiopathy and can present with a pregnancy-related hemolytic uremic syndrome. There can be beta long chain 3 hydroxyacyl dehydrogenase deficiency, LCHAD, may be the contribution to the pathogenesis of HELLP syndrome. But evaluation for these genetic variants is unnecessary and there is no identified role in a clinical management. So we can say that the HELLP syndrome may be there because of LCHAD. This can be one of the genetic mutant can be the reason, but it is not there. In a Winston 1982, HELLP syndrome was diagnosed. Again, hemolysis, elevated liver enzymes, and low platelet. The reported incidence is 0.2 to 0.6%. Preeclampsia developed superimposed HELLP syndrome, 4 to 12%. Elevated perinatal mortality and morbidity. Maternal mortality more than 35%. It's a worst thing. We should be further about. Now, factors to consider, that's first is the erythrocytic morphology, platelet disorders. There can be a renal compromise. There can be hepatic disorders, immunologic disorders, and genetic disorders are there. So, most important HELLP syndrome, the possible pathophysiology, again with the causal agents, are increase in a volume, fetal presence, decidual cells, sometimes vasospasm, or a deficient vascular repair or idiopathic. It can lead to vasculoendothelial disorder. It can lead to platelet aggregation or the consumption. It can lead to fibrin activation or the consumption, and it can lead to selective organ ischemia or insufficiency, and variable manifestations are there. The causal factors include thrombocytopenia, microangiopathic hemolytic anemia, and periportal necrosis and distinction of the liver's glycine capsule is there. So, the diagnosis, especially in the third trimester, first days of postpartum in 31%, and antepartum diagnosis is made in 70% between 27 to 37 weeks of gestation. Now, we have to differentiate HELLP syndrome with acute fatty liver of pregnancy or thrombocytopenic purpura. So, how to differentiate between the HELLP syndrome and AFLP? It's a rare but severe liver disease and occur in third trimester. It can cause similar symptom to the HELLP, abdominal pain, nausea, and vomiting. And the TTP is the thrombocytopenic purpura, is a rare blood disorder. And this can also lead to low platelet count hemolysis, which is seen into the HELLP syndrome. Then third, we have to differentiate, and they can lead to DIC, is a condition where blood clot is throughout the body, leading to organ damage and bleeding. And it is a complication of a variety of medical condition. We have to differentiate it with the HELLP syndrome. Acute cholecystitis, there's an inflammation of gallbladder, abdominal pain, nausea, elevated liver enzymes, and can be mistaken for the HELLP syndrome. Preeclampsia, it's a complication characterized by high blood pressure. Protein in the urine can similar symptom with HELLP, and we have to differentiate with this. Other differential diagnosis, it can be viral hepatitis, cholangitis, cholecystitis, upper urinary tract infection, gastritis, gastric ulcer, acute pancreatitis, big list of it, but we should keep all those things in mind. Thrombocytopenia may be due to the immunological, folate deficiency, SLE, antiphospholipid syndrome, and rare disease which mimic the syndrome are TTP, is a thrombocytopenic purpura or hemolytic uremic syndrome. Then the criteria for establishing the diagnosis of syndrome are again hemolysis, elevated liver enzymes, and the low platelet. So hemolysis is abnormal peripheral blood smear, and there can be a blur. There is reveal the spherocytes, shiocytes, and triangular cells. Elevated bilirubin is also there. Liver enzymes are elevated, and the low platelet count is another important point. Now, we can also observe the excessive body weight increase. Ophthalmic disorders can be there, minor alteration, cortical blindness, retinal detachment, various hemorrhage can be seen, and the vitreous hemorrhage can be seen. Alpha-fetoprotein, LDH, serum peptidoglobuline, and hematocrit are another important point we should able to observe. Approximately 90% of the patient present with a generalized malaise, 65% patient with epigastric pain, 30% with nausea and vomiting, and 31% with headache. There are the risk factors for the maternal morbidity, and a laboratory we should be worried about. If the platelet count is less than 50 and there is a epigastric pain, LDH more than 40, nausea, vomiting, eclampsia, ALT is more than 100, AST is more than 150, creatinine is more than 1, and clinically there is abruptio placentae, hypertension, eclampsia, vomiting, and all these things should be considered, and these are the risk factors for the maternal morbidity and the mortality. Now, we can classify the HELLP syndrome based on the platelet count. This is a Mississippi classification. There are 3 categories: class 1, class 2, and class 3. Class 1, when the platelet count is less than 50. Class 2 is platelet count between 50 to 1,001. And class 3 is between the 1 and 150. This is the Mississippi classification. And it is a triple class system. And the further classification of disorders is based on the nadir count any time during the course of the disease. Class 1 and class 2 are associated with hemolysis, that is LDH more than 600 and elevated AST. Class 3 requires only LDH more than 600 and AST is more than 40, addition to the specific platelet count. Class 3 HELLP syndrome is considered as a clinical significant transition or the phase of HELLP syndrome which has the ability for the progression. So if the patient of class 3 and they can turn into 2 and a 1, so we are worried about. Then this is the Tennessee classification. First was the Mississippi classification. This is a Tennessee classification system. CBI has proposed strict criteria. Either it's a true or complete. HELLP syndrome is intravascular hemolysis diagnosed by the abnormal peripheral blood smear, increased serum bilirubin, and elevated LDH level. So AST is more than 70 and LDH is more than 600 is another important point. So complete HELLP is microangiopathic hemolytic anemia with severe preeclampsia, LDH more than 600, SGOT more than 70, and thrombocytopenia less than 1. So partial HELLP, one or the 2 of the above is included, is a partial one. Now the management of the HELLP syndrome, how to manage the cases of HELLP syndrome. So first and foremost, we have to differentiate the HELLP syndrome. That's first from the thrombotic microangiopathies. So thrombotic, TTP, purpura, microangiopathic anemia included by sepsis or drugs. Hemolytic uremic syndrome is a fibrogen consumption, disorder CID, and these are the other diseases, especially the glomerular. So all the differential diagnosis, we have covered the name in a previous slide. So this is a repeat of the slides, can be lead to HELLP syndrome. So first and foremost, we have to differentiate diagnosis. Now we have to evaluate the maternal condition. First is the complete hemogram, platelet less than 150, elevation of the liver enzymes, that is a transaminase, and the LDH is a sign of hepatic dysfunction. That renal function is also important. Sometimes deficiency in a renal function is observed at the late stage of illness. Creatinine, uric acid levels are variable. Bilirubin, unconjugated bilirubin is increased due to hemolysis, but rarely above 1 to 2 millimeter. Now, after determining the maternal condition, the fetal evaluation is important. Gestational age, well-being, non-stress test, tolerance to the contraction test, and a biophysical profile. Use corticosteroids between 24 to 30 weeks to improve fetal pulmonary, neonatal pulmonary function, and the maternal and perinatal results. Now, the important point is first and foremost, control the hypertension. 80 to 85% of the patients need control of the BP to avoid the significant maternal and perinatal mortality and morbidity. Treat systolic BP when more than 150. It avoids the placental function, maintaining the diastolic BP not less than 80 and 90. Now the choice of hypotensive medication. First is hydralazine, labetalol, and nifedipine. Hydralazine bolus of 5 to 10 milligram IV every 20 to 40 minutes. If ineffective and unable, use a labetalol, nifedipine, and sodium nitroprusside. Labetalol, initial bolus 20 milligram IV with increased doses, satisfactory BP is obtained, and nifedipine in a normal doses. Sodium nitroprusside is a fast-acting agent, but which can be used by the hypertensive crisis when all the hypotensive drugs have failed. Loading dose 0.2 microgram per kg per minute and increasing up to 10 microgram per kg per minute. Above these doses, there is a greater risk of cyanide intoxication of the fetus. When using, remember it's a photosensitivity and severe rebound effect. Now, classical histological lesions into the liver, there is a periportal and a focal parenchymal necrosis with the deposits of hyaline-like material, intrahepatic hemorrhage and subcapsular hematoma, eventual rupture of the Gleason capsule. So the treatment, blood transfusion if there is a anemia, bed rest, continuous monitoring of mother and baby, magnesium sulfate to prevent seizures, blood pressure medications, and corticosteroids for the development fetal problem are there. If there is a convulsions, chances are magnesium sulfate is important. 4 to 6 milligram IV followed by continuous infusion, individualized according to the patient, continue 44 hours, more postpartum clinical, and contraindication for magnesium sulfate use phenytoin. Then chemotherapy, again aggressive use of dexamethasone, HELLP syndrome, severe severe thrombocytopenia has eliminated virtually all need for the platelet transfusion. Other therapeutic alternatives is a plasmapheresis, immunoglobulins are given. Then the management of the labor and delivery, considering the termination of gestation and the patient's HELLP is determine the age, gestational age, maternal and fetal condition, fetal presentation, cervical maturity, timing of delivery if more than 34 weeks, deliver. If less than 34-week gestation, administer corticosteroid, deliver within 48 hours. Now, optimizing the perinatal care. The main risk of the fetus pregnancies HELLP syndrome is prematurity. Use of corticosteroid decrease the morbidity associated with the pulmonary maturity and a preterm babies. Delivery should be in the center with the capability of treating these children. The major risk of cardiopulmonary instability is there. Now, hepatic rupture. The incidence of hepatic rupture varies 1 in 40,000 and 1 in 250,000 pregnancies. So, the chances are very, very less. Infarction is even more rare, and it's believed to the continuum of the preeclampsia areas or hemorrhage resulting these capsule and intraperitoneal hemorrhage can occur. Advising for the future pregnancy, the risk of recurrence of preeclampsia, eclampsia is 40 to 43%, and for the HELLP syndrome is 19 to 27%. The risk of recurrence into preterm delivery is high, about 61%. Now, conclusion, HELLP syndrome and its management still poses a problem in the modern obstetrics. Precise diagnosis, early treatment, non-mineral corticosteroids such as dexamethasone may help favorable maternal and perinatal